Lenticule extraction is becoming more popular due to its minimally invasive and ocular surface compatible nature. Retained lenticule is a recognized intraoperative complication of kerato lenticule extraction surgery. Rescuing a retained lenticule is a challenging task as one needs to reopen a pocket and access the retained lenticule. The options available are repeat lenticule extraction below the cap, surface ablation or circle software. All CLeARsurgery platforms do not offer the option of circle software. In such case, using intraoperative OCT guided extraction is useful. A 33-year-old female presented to us for laser vision correction. Her manifest refraction was -4.5 sphere with -1 cylinder at 30 degree in right eye and -4.5 sphere and -1 cylindrical at 160 degree in the left eye with the best corrected visual acuity of 20/20 in right eye and 20/30 in the left eye. The corneal tomography and biomechanical indices were within normal limits in both eyes, with a pachymetry of 554 in the right eye and 551 in the left eye. Lenticule extraction CLEARsurgery was planned with a cap thickness of 110 microns and optical diameter of 6.4 and 6.5 mm and residual stromal bed of 303 and 316 respectively. The right eye surgery was uneventful. In the left eye, the dissection was difficult because of the loose epithelium. There was a fear of cap tear or perforation and a chance of false plane of dissection. Second incision was also attempted, however it was difficult to proceed due to loose fragile epithelium, hence the lenticule was retained. On postoperative day 1, the left eye uncorrected distance visual acuity was 20/400 with -4.5 sphere and -3.5 cylinder at 140. In the present case, dissection of the lenticule from the second cut incision was also attempted. However, we could not succeed the same due to loose fragile epithelium and fear of cap tear and perforation. Secondly, one cannot perform surface ablation as the post-surgery recovery is slow, painful and involves a risk of corneal haze. Also, its outcome may not be predictable due to the presence of retained lenticule. Circle software has been developed to convert cap into flap and retreatment following small incision lenticule extraction. We had two options. Once the epithelium has healed, open the same incision, dissect again and extract the lenticule. But if this failed, we had no fallback plan B. The second option was to make a flap and remove the lenticule in toto. A unique feature of Zimmer femtosecond laser is intraoperative OCT. Measuring the intraoperative OCT pachymetry is more important as in ablanated state, the resultant cap thickness is ascertained correctly. Intraoperative OCT showed 120 microns after ablanation. It is better to take 5-10 microns more than less because if one takes less, one may be in the plane which is more anterior and the access to lenticule becomes more difficult. Because of the large numerical aperture and small gas bubble size of 1 to 2 microns with a standard deviation of 5 microns, the laser cut is very predictable and precise. The suction ring was centered over the pupil and suction was applied. Docking procedure was initiated and a 120 microns flap was made with the femtosecond laser pulses. A spatula was passed across the flap starting at the hinge and sweeping inferiorly. The flap was gently lifted up. The lenticule was carefully separated from beneath and the lenticule was removed in toto. flap was placed back and interface wash was done, followed by flap edges being dried. A bandage contact lens was inserted. Postoperative, at 1 month, the uncorrected distance visual acuity was 20 by 20 blur with auto-refraction showing plano with 0.5 cylinder. Recently, Sajdev et al. Demonstrated the utility of Circle software from Smile platform for enhancement post-CLEARsurgery. However, in the present case, we did not have an access to Circle software as it is not compatible with the CLEAR platform. Thus, we used an intraoperative OCT, a unique feature of CLEAR platform, to create a flap and gain access to the retained lenticule. This video demonstrates the technique to rescue a retained lenticule using an intraoperative OCT. Intraoperative OCT can be helpful to match the cap cut of the lenticule with the LASIK flap cut. Thus, using this technique, it is possible to rescue a retained lenticule in the absence of Circle software.